Okay, good afternoon, everyone, and welcome. This is the second installment of a collaborative webinar series on HIPAA security and privacy issues. And the webinar series is sponsored by Kesis Health and QIP Solutions. Today, we are going to continue looking at various aspects of HIPAA safeguards. My name is Adam Bullion. I am your moderator today and throughout the series. By way of a little housekeeping at the beginning, our presenters have agreed to take questions throughout the course of the presentation, and we will also reserve some time at the end for questions. Participants can use the raise hand function, which is under the mood button at the top of your screen. Then I can unmute you and you can address your question directly to the presenters. Alternatively, you can use the chat function, which should be at the lower left-hand corner of your screen. That will come through to me, and then I will address that to the presenters. So our topic today is on remediation plans, and we will be discussing how to get from a risk assessment, which we discussed in our first webinar, to a remediation plan. And we are honored to have two distinguished presenters for this webinar, Susan Pretner and Mark Pretner of Kesis Health. Susan is president of Kesis Health, which provides consulting focused on HIPAA and high-tech compliance. She has more than 30 years of experience in the healthcare industry, including extensive software design and development work in health administration information systems. Thank you for joining us, Susan.
Thank you.
Mark is vice president of Kesis Health. He has over 20 years of experience with IT project implementation, design, and management within the healthcare industry. And he is a thought leader in creating an organizational culture of compliance. And with that, I will turn it over to Mark to begin our presentation.
Thank you, Adam. Thank you for the remarks. Thank you for those who have joined us. We'll stay condensed and we'll stay focused and we'll move as quickly as possible through our presentation time. But as Adam stated, if you do have questions, feel free to submit those. We'll do our best to answer those questions. So, implied within the HIPAA security rule is that the organization is working to protect patient information with its risk management program. I want to focus on that word there, that key focus of this being that word program. As we've seen with multiple cases like the one you're looking at on the screen here on the slide, your ability to demonstrate active compliance management activities that are closing gaps in security will be paramount to avoiding substantial business exposure associated with inaction. So what you'll see today, what we're going to discuss, our focus will be discussing how the fundamentals, the next step here of remediation planning, and then subsequently how driving your organization for a continual risk management process will be pivotal to success. Remember, HIPAA is not a project. It is a continual journey, much like your billing management and your clinical management strategies, how they have continually evolved and had to adjust and change. Your HIPAA program will need to be structured with the same rigor. All right, so who should lead what we're talking about? We've been through the assessment in our last discussion. Obviously, inherent within the rule, you do have to assign, at a minimum, at least one person to take on this active role of compliance, being a security officer or privacy officer. Obviously, it would be great to have multiple team members involved, if at all possible. We know this is a challenge for many organizations, so just due to your size, budget constraints, time, and resources, that's very hard to ensure that. But one of the key factors, the ownership that is taken on for this work effort must get, and everybody must have the complete attention of the organization. That's one of the reasons we've seen really, HIPAA success has been elusive for many organizations, because these efforts have been viewed as a project. they've tended to, and as many have tended to identify the problem areas from the assessment, but then when they're siloed off in a project, there's no one champion there to take the efforts and move them forward. There is no ownership ability moving forward. There's no exposure that the business sees in its processes that will affect the remediation effort that will need to be occurring in order to close those gaps. So you have to get that effort viewed as a functional business process that can be addressed by the organization. So that security and privacy officer, once you are identified, if that becomes your role, you got to work really hard with executive management and their ownership to understand their involvement in this process as well. It cannot be off in a silo, off in a project. It has to be the entire organization getting its hands involved in this effort. And just one little side note, I want to say it's not a requirement that an organization has to spend every bit of its money and resources to close every gap it detects in its assessment process. But you must, as an organization, have a documented explanation for the decisions that are made, which will only be strengthened with dialogue of the executive management along with the responsible compliance officer. So if your organization does not feel comfortable doing this, just please look for outside assistance or expertise to help you structure, this vital communication and documentation process. Now what we'll do is I'm going to transition over to Susan. Susan's going to take you into some very specific real-world examples of what to expect and start to highlight some of the things that we're talking about when we talk about remediation planning and moving forward with remediation success.
Okay, thank you, Mark. And we spoke last time about the very important need to do an assessment and analysis of what your gaps are. And I think what you can expect from that process is to definitely have gaps. It's highly, highly unlikely, especially since healthcare industry is just getting into really paying attention to privacy and security, that you wouldn't have gaps in what the expectations are. The two most prevalent that we're seeing and the industry is being put out in all kinds of newsletters is encryption of your endpoints and real poor password management. And these are two just very basic business processes that as you get into mobile, using mobile technologies, your exposure increases. As the number of interfaces that you have increases, and you're going to become more and more electronic and depending on that world, you need to look at what's called your endpoints. Where are things going? Where's PHI going? Where's it coming from? Password management is still a huge issue in the healthcare world. Not only are people not using them, if they're using them at all, they're not using strong enough in passwords. So these are two things that you might see immediately as you come through a checklist of assessments or in your assessment process. The planning and execution of other major business processes are the other things that seem to be lacking. You're going to see in a checklist of the rules an IT security audit, for instance. And, what is your network vulnerability? How secure are your technologies? So this is something that needs to be planned for. It's not necessarily a cheap thing that gets to be done. But these are some of the processes that would be done within remediation work, business continuity planning, disaster recovery planning, and not just the planning, the testing of those plans, the constant rework of that has to go on as you change technologies and bring more things into your practice. I think there's a lot of misunderstanding about a disaster recovery plan versus backing up your data. That is one function that would happen within your disaster recovery plan, but there's much to do around an actual disaster plan besides the one function of backing up data. The other expectation is in order to really get this remediation work accomplished, in many cases you need to develop some kind of budget to get you there. It does take some research. It does take some experimentation with additional technology potentially. And, you know, our advice, as Mark mentioned, was engaging a third-party contractor if needed if your internal resources are really not knowledgeable about what is being asked in the assessment. In order to get those projects done, you're probably going to need some expertise. If you're outsourcing your IT, that's an excellent source of information, of ideas, of experience that would be very valuable to you. And I think a lot of times we see resistance to go back to those IT vendors because, you know, the thought is, oh, they're just going to charge me more money. But they may have alternatives that are very reasonable for you and your size that could help you be more secure. Whoops, I got a little gay with that. We'll go back to the next slide. So what you're trying to do in terms of remediation is really figure out what needs to be done first. Okay, after you've done some kind of checklist or assessment and you've answered those yes or no control questions, your requirements are really called controls, and how much control do you have over these issues that you're looking at. So as we've said in the slide here, it's not rocket science. These are business processes that most other industries have already put in, and healthcare is just trying to come up with really common standards that are already out and applicable to any business, not just healthcare. So you're looking at your technical vulnerabilities and your non-technical. This is another area that people sort of ignore, that you haven't maybe done any training for your staff, and that is a great exposure for you if they really don't understand their requirements toward protecting health information. So you're looking at threats to your practice. Do you have a lot of natural? We're in Alabama, so this is a constant tornado threat. If you're at the coast, you've got hurricane threats. There's human, again, the training, the impacts. I think over half of the breaches that have been publicized are due to human error. I left an unencrypted laptop in my car. I didn't lock my car. Things like that are going on day in and day out reported. And environmental, you know, are you in a high crime area? Do you have a lot of power issues? So there's threats that happen to your practice, and what you've tried to do in terms of your assessment and your analysis is figure out what's the likelihood of these things are going to happen to us, and then how vulnerable are we because we don't have controls in place to handle that. So that's basically how you're trying to decide what to remediate. Well, where do you have the greatest likelihood that a threat could really expose your practice? In terms of prioritizing those gaps then, and you're looking at, the rule is requiring you, which would be a high impact gap that you would have. They're requiring you to do some things in particular. No questions asked, you're going to be required to do it. If it's addressable, as you see, is another, some of the rules or some of the requirements and controls are considered addressable. But that doesn't mean they're not also required. It means you have much more flexibility in terms of how you're going to implement that control. So the caveat there is if you are a very healthy, high income practice and you have the wherewithal to put in a strong, for instance, encryption package and you choose not to do that, that's really a high-risk thing for you to do. As you may have read on that first slide with Concentra, they realized through their risk assessment that they had not encrypted their laptops. And they started the project, just never bothered to finish it. So when they lost one, their exposure was huge, well, to the tune of $1.7 million. So, and that was because they were assessed or evaluated by the auditor as being, you were fully capable of completing this project to reduce that risk, and you didn't bother to do it. So even though it's addressable, be aware of what your capabilities are, because the expectation is if you have the wherewithal to spend a few dollars to put in more rigorous security, I think you'll be expected to do that. So your controls have to be reasonable and appropriate for your facility. If you're a small one-man practice, it's a highly different situation than if you're a multi-specialty clinic, and that's how it would be looked at. If you have ad hoc controls in place, you have good, strong ad hoc, they're just not documented, those become lower risk exposures for you. So if you feel like your people are trained, that would be the last thing I would do is to go back and document that. At least you would feel like this is a lower risk thing for us, everybody knows how to handle it, and they've been trained on this procedure. And so your task would be later on to come back and document that. Your greatest exposure is going to be anything that you don't have a procedure of any kind, even an ad hoc procedure, to accomplish that task. So the remediation plan is very simple, I guess, in some respects. You do need a plan. So if you've done an assessment, if you've analyzed your gaps and have a way to prioritize them, you need to document what is going to be your plan for the next year, for instance. And we're really going to try to accomplish these things. As Mark said, to have any way to demonstrate that you have an ongoing risk management program, you would need to document that you actually have a plan to execute, and you're working down that process. So it causes you to stop, evaluate, what are those things I have to actually budget for? I may not be able to accomplish them until later in the year because I need to save some money to do that. Or you may need to test some things. It's going to take you longer to resolve some gaps. So this is just part of instituting a real program management or a project management process where you're documenting that you're moving forward, you have a plan, and you would keep track of the fact that you either had to stall and do some testing of technology, for instance, but you're documenting that process as you're going through. We advise, and we do this working with our clients, is you use agendas. You have some kind of formal review of your risk management program. You do minutes of that. You determine if you have issues you have to work through. A way to document that you're keeping this program going and it's alive and well in your organization. And ultimately, you will have to, I'm sorry, I tapped and I shouldn't have, reassess. So the expectation by high tech is that you reassess your program at least once a year. The HIPAA rule says at a minimum every 3 years you will totally reassess your organization. But it also says when you change technologies, when you change key personnel, when you change your location, you will reassess at that point because things have changed. So you don't necessarily wait till the end of the year. If you have major things that have happened to your practice, it causes you to go back and look at your policies and procedures that may have been impacted. So that reassessment is, again, an expectation that you'll have a minimum reassessment, even if nothing seemed to change in your practice. But definitely look at your policies and procedures if you've had some major technology changes or other administrative changes that happen in your practice. And, of course, the last little bullet there is documentation, documentation, documentation. This is what's being requested of the people who are being audited. And, of course, the expectation as you read through the HIPAA rule is all of this will be documented. It's the same thought that you have on your clinical documentation. The better it is, the better off you are when you're audited. And so that's the same situation with HIPAA compliance, is they are striving for you to be able to document the activities that you've had going on. Adam is going to follow up on the next couple of slides and finish off our webinar.
Thank you. Thank you, Mark and Susan. Some very good points you brought up. One thing that I sort of heard throughout, and I know Mark really addressed it, is that this is a program, not just a one-time project that we go through and and leave it at that point. And I just recently received an excerpt from an audit letter, which is highlighted on the slide here. I think it demonstrates that pretty well. And as you can see, the request isn't for what was done in 2012. It's hitting on the point that, what have you done? What have you done for me lately? Kind of a thing. What you did in 2012 isn't good enough now, and we need to see what you've been doing recently. We need to see a new risk assessment, and we really want to see that those things are continuing to go on, and that this process continues into the future. And just some highlights from what Mark and Susan had said on this slide that we're talking about. Assigning a project manager, reviewing and continuing to monitor those procedures. And another thing, just sort of as a summary that I was sort of thinking about as the presentation unfolded, was the notion that why are we doing all this? What is all of this about? And it really, if you go up to the 30,000 foot level, I get the impression that really it's about privacy. And it's about ensuring the privacy of medical records. But I think we lose sight of that when we're talking about encryption or we're talking about password strength. But we're doing all that so that we can keep, health information private, which is important not only for the consumer, for the patient, but also for the providers, because that is where a lot of their trust comes from. So we have a bit of time at the end, and I have received some questions. So I'm going to address those, and I will let Mark and Susan decide who wants to answer them. So one question that I received is, how do the minimum necessary requirements change for small practices?
How does it change for a small practice?
Yes.
The minimum requirements have to do with actually the data that you share, right? Is that the question? Would you read that question again? How does
Sure.
the minimum?
How do the minimum necessary requirements change for small practices?
Okay, that really doesn't. That's one of those things that apply to anyone who's sharing information, medical information. So whether you're small or large, you have to assess when you make data available. Let's use your people as an example. If you have administrative tasks or administrative staff that never deals with the clinical record, well, there's no reason to give them access to that part of the documentation on your electronic medical record system. They may need the billing information, they may need the schedule, but they don't necessarily need the clinical data. So you have to assess and determine in your access management policy who should see everything. And also, when you get a request from, let's say, the insurance company regarding a specific claim, well, you don't send them the whole medical record. You're responding to a request that's very specific in that regard. So that whole minimum necessary, it applies whether you're a one-doc practice or you're a multi-specialty clinic. I hope that answered that question.
And if not, Susan, the other thing I would add to it, when you talk about requirements, most of everything is derived from NIST standards, and inherent with many of the technology or the technical components, there is a technology standard that you kind of adhere to, and that doesn't affect your size, but what it does allow for is flexibility. There are many ways to encryption. There are levels to encryption, and there are some minimum levels. And that goes back to your expertise of working with your technology vendor or some outside expertise to help you understand not only your size or your commitment or your exposure. That the idea here is that you understand your exposure and your endpoints enough to know what level of encryption would need to be put in place. But those necessary requirements are based off of some national standards that most firms have a good grasp of when they are obviously selling you technology components to satisfy these requirements.
Excellent. I think we have time for at least one more question before we wrap up. We are going to try and keep this to our 30-minute allotted time. But Mark, maybe this question is best answered by you, because you touched on earlier about the need to have one champion for the remediation process. But let's say, we have a small practice, and maybe one person can't do all of the work. Do you have any tips on how to recommend delegating some of the remediation tasks? Or have you noticed anything in your work? Is it difficult to sort of organize all of that? And, sort of any tips or tricks you might be able to pass on?
Yeah, there are many different components to that. You definitely, for a small practice, it is difficult. Time management is difficult. Many practice managers are wearing 45 different job titles and hats to have to accomplish. One of the things are to look for some tools that will help you in that, what we would call activity management, or the ability to establish an identification of who's got a responsibility for closing this gap. And many times, and Susan alluded to this a little bit, a lot of our smaller clients or our smaller practices sometimes have a very good relationship with their IT vendor. Sometimes they do not, or they're truly in an ad hoc mode where they have to pay for every time they talk to them, or they're in a very reactionary mode with that vendor. But many times, don't be afraid to engage them in these conversations to help you with those discussions. I think many times folks just get intimidated by the language and don't know or try to go ask some resources that may help them through that path. One of the other things to use, try and create a calendar of review for some of these activities. The reminder capabilities inside a calendar for checkpoint is always a good reminder back to an individual. Oh, I've got that policy I've got to take a look at, or I've got that procedure that we've got to, close down. But one of the things is just work hard to identify responsible parties for closing these gaps. Obviously, technical gaps, you're really going to lean on technical resources. But when they're administrative, do your best to identify who inside the organization is best, championed to hold on to that effort for an administrative effort or a physical effort. Many of the physical things are dealing with your, if you lease space, then your building attendant, asking them for what is our fire plan, or what are our disaster plan capabilities. Sometimes you can even pull from them information that'll help you in creating your continuity plans. So many times it's just trying to rely on some of the resources around you to help populate your information in order to document and close these gaps.
Great.
Susan may have some other techniques if she wants to pipe in.
Susan, I actually have received one more question that I think would be great for you to address, and then we'll briefly address, because we are at 1:30. And I'll paraphrase. Do you get points for participation, an A for effort, if you will? You mentioned the slide earlier. There was a risk assessment. They identified that they needed to encrypt, but they didn't. Let's say they were in the process of encrypting, but didn't get all the way through that, but there were documented efforts. Maybe it's a small practice and they can't do it as quickly as somebody with a lot of resources. In your experience, do practices get points for trying, even if they haven't completed it as quickly as maybe they should have or could have?
Well, I think that's a possibility that we have seen. They are looking for you to have a process. And so if that process is documented and you've said, we had to stop this effort because, you know, we had a tornado, or, you know, we had something that got us off course. You set a plan, you try to achieve that plan, but the documentation is critical. And I think many auditors, what's happening today is, and we've seen this, alluded to that on that last slide, that they're asking you to say what effort have you made, but they will assess you based on your capabilities. They really will assess you based on your wherewithal. So I don't think you want to be blasé about saying, oh, we're just going to do one thing this year, depending on how exposed you are. You can always train your people at no cost, technically no cost. So that is another effort that you can document that you have done. Even though, you know, for instance, your policy on laptops is never to leave it in the car, never to take it out of the building or return it within, you know, whatever. So there's policy that you can do. If you're counting on human beings for everything, you're going to have a failure there eventually. So you just need to continue to take the next steps. So I do see that auditors are trying to base it on reasonableness for you. So I do think the documentation could save you in an audit, especially in
and don't be and don't be afraid of the. Sorry.
Go ahead, Mark.
Oh, I was just saying I didn't know you were finishing up. I was saying don't be afraid of the no answer of why the particular practice did not implement something. I think that's kind of the bigger thing here is that if you are showing a consistent dialogue that you as a organization have taken the time to discuss it, to evaluate it. You obviously, your gap analysis, you went through your process of what this was a threat to my organization or this was not. We didn't view this as a vulnerability. You have to be able to capture that. You know, the documentation, it's proof. And that then the discussion with an auditor gets down to, well, we want you to do that versus, well, you identified it and didn't discuss it at all or had no plan of action to do anything about it. That's where your trouble's going to come in. So no matter what you're choosing to do, it's just as important to document what you have not done and the reasoning behind that.
And that's
Great.
true. You know, worst case scenario is you would be put on a corrective action plan rather than fined and told, you know, you have 6 months to correct this or whatever amount of time they deem reasonable. So there is an option that could happen to you as well, that they would be back, but they would give you the time to finish or implement a control.
Very good. I think we could probably use the rest of the afternoon to cover more of these topics. Unfortunately, we have exhausted our time, but Mark and Susan's contact information is on the screen. We have recorded this webinar, and later today, everyone will receive a copy of that recording as well as Mark, Susan, and my own information in an email, as well as a copy of the slide deck. And feel free to contact us if you have any questions. We have our next webinar planned. It's a Wednesday, June 11th at 1 p.m. Eastern Time. And we will be discussing tactics to implement specific privacy and security safeguards. And we'll have 2 more excellent guests lined up who will provide useful insights. You will also receive a registration link to the webinar in the email that should come later today. Again, I want to thank Mark and Susan for their time. I want to thank everybody who joined us, and we'll look forward to hopefully you joining us on the 11th of June. And feel free to let us know if you have any questions in the interim. Thank you, Mark and Susan. Thank you, everybody else, and have a good rest of your afternoon.
Thanks, Ed.
Thank you, Adam.